Okay, sorry about that. I'd like to now call the Health and Human Services Committee to order. Sharita, would you please call the roll?
Alderwoman Ingracia.
Present.
Alderwoman Tyus.
Present.
Alderwoman Green.
Present.
Alderwoman Martin.
Present.
Alderwoman Navarro.
Present.
Alderwoman Middlebrook.
Present.
Alderwoman Rice.
Present.
Alderman Todd. Chairwoman Spencer.
Present. With that, we have two items before us today. The first is a bill, Board Bill 25, which is a bill that was prepared by the Health Department. This bill authorizes the Director of Health to enter into a contract with the National Association of County and City Health Officials, otherwise known as NACHO, an organization we've heard a lot about in the news lately. This is part of a CDC grant. And with that, I'd like to hand it over to Craig Schmidt, who will be presenting on this bill. Before we do that, I'll entertain a question from the Alderwoman from the 8th.
Thank you so much, Madam Chairwoman. On the minutes from the I believe approved those, and there's an error in there that we need to correct. Do we need to pass the minutes from last meeting?
From the last meeting of the Health and Human Services Committee, let's see. What is the error that you noted?
The Miss Teresa Page is listed on Board Bill number 208 as the name is misspelled, and she's listed as a federal public defender, and that was the asbestos bill. And so we need to correct her name. And I'm not sure what we should use as her title there, but I think if we could correct that, that would be great.
Thanks, Alderwoman from the 8th. You know, that is a carryover from last session. We do need to approve the minutes from the last meeting there. Make a note to get those changed. If there's counsel on whether or not we need to amend those before moving, if we can move those to the next meeting, or can we just, with that amendment, with those two amendments addressed, approve them and move forward?
Right. What we can do, you can approve them, and I'll note the change, and then they'll be on the next meeting so you can see that the changes has been made.
Thank you, Sharita. That would be great. With that, I'll entertain a motion to.
Can we repeat the change that we need to make on the minutes?
Yes, we need to change the spelling of Miss Teresa Page, Teresapage, I believe. I will verify that for you, Sharita, and send you an email. And then her title, she was not a prosecuting attorney. She we'll have to get her title for that, her appropriate title.
Okay.
Alderwoman Rice, thank you for noticing that and pointing that out. Ms. Page did a phenomenal job testifying before us and has been an incredible advocate for safety workers. With that, I'll entertain a motion to approve the minutes from the previous meeting with those two adjustments.
So moved.
I'll entertain a second.
Second.
Sharita, would you please call roll?
Alderwoman Ingracia.
Aye.
Alderwoman Tyus. Alderwoman Tyus.
Aye.
Alderwoman Green.
Aye.
Alderwoman Martin.
Aye.
Alderwoman Navarro.
Aye.
Alderwoman Middlebrook. Alderwoman Middlebrook. Alderwoman
Aye.
Rice. Okay, Middlebrook, I got you. Alderwoman Rice.
Aye.
Alderman Todd.
Aye.
Chairwoman Spencer.
Aye.
9 aye votes.
Okay, first order of business would be to put to the Board Bill 25. This is the bill I described earlier, authorizing the Director of Health to enter into a contract with the National Association of County and City Health Officials. And with that, I'd like to turn it over to Craig Schmidt from the Health Department, who will be presenting the bill to us.
So Alderwoman, I think that you set it up very well. It is for authorization to do that. We would be working with NACCHO, who is using a toolkit that the Centers for Disease Control and Prevention are creating to try to provide assistance with how public health and public safety, namely the police department, would work together with other partners using this toolkit, which is what the purpose of the grant is, so that we can give them feedback and they can work with us to see how well it's working. They have some other locations in the country. They're going to try to get a better sense of how this might work out in terms of working with various communities to try to reduce the prevalence and impacts of substance use disorder. Of course, that continues to be an issue in the city of St. Louis. It's a small grant under $28,000, and this would allow us to work with CDC for the implementation of this, sign that contract.
Thank you, Craig. Can you tell us a little bit more about the amount? Is that in line with our population? Is that determined?
No, so they asked us to, so we're bringing together, there's an outside consultant with Project Safe. At one point, we were anticipating that he might have to fly back and forth, which is not the case any longer. But some of the time that our epidemiologists and others coordinating this here in the health department would spend, and then some efforts if we looking at implementing some items with regard to education and direct involvement with individuals out in the community when public safety and others are working with them, that we would have materials that we could provide them as part of this. So that's how it came. It's the budget basically, were those materials in the time, staff time.
Mm-hmm. And Craig, can you give us a little overview on NACCHO, that organization? We've heard a lot about it in the national news recently, but can you just give us a short overview of that organization?
Not really. It's just as the name suggests, which is the county and city health officials. And I know that they do a lot of things with regard to many of the standards. I know when we look at health and all policies and so many of the things that we work on, they are a national organization that tries to put forward many of those public health standards that we try to work on when we were doing some of our efforts with accreditation and other items with the core elements of public health. They set forth a lot of those.
And those are guidelines that we recognize. The organization is one that you would consider
yes.
a nationally recognized organization that's issuing guidelines and other information to cities and counties, correct? Their health department.
And the cities and counties leaderships are part of that organization as well.
Okay. Thanks, Craig.
Sure.
And now I'd like to turn it over to my committee members for questions. I'll start with Alderwoman Ingracia.
Thank you, Madam Chairwoman. Craig, thanks for being with us to answer questions. Is this the total amount of the grant, the total amount of what this program will cost to implement?
It provides a little bit of the time in those materials for the program, yes.
Okay, so will there be any other resources allocated to implementation of this program?
So they are providing some technical assistance as we go along, and that's one of the good things about the program as well. So we'll be working with the CDC. They're supposed to have what they call an implementation science consultant, so that they will work with us as we try to implement this tool.
Okay, great. And I noticed in the contract, it says, try and find it. It talks about a primary funder and that.
Yeah, so this is money from the CDC going through NACHO, and then we're working with NACHO directly.
Okay, so the primary funder is the CDC.
I don't know which of them is the primary funder. We're working directly with NACHO, and CDC is providing them the money.
Okay, do you know who prepared the contract?
Yes, that was prepared by NACHO.
Has it been reviewed by anyone in the legal department?
It was reviewed by legal. NACHO basically said that this was their basic contract, and our legal was okay with that.
Okay, and do you know who from the city councilor's office reviewed it?
We always send that to Barb Burkett.
Okay, thank you. No further questions. Appreciate your time.
Sure.
All right, thank you, Alderwoman Ingracia. Alderwoman Tyus. Alderwoman Tyus, you're on mute. Do you have any?
Actually, the participant is unmuted, so I'm sorry. Good morning, Madam Chairwoman and members of the committee. Good morning, Mr. Schmidt. How are you this morning?
I am fine, Alderwoman.
Great, great. So this grant actually started, the period for the grant started in February?
Yes, and we're anticipating that because of the pandemic that they're going to push this forward, and so it'll go shortly to start and then go through the end of the year. But yes, that was the original intent.
And so, so right now the dates are from February 18th through July 31st. So if we were to extend this, do we have to apply, or is it automatically extended? How does that work, if you know?
So they are working through that right now, Alderwoman. And so NACHO has indicated that they're going to send us something that will have that extension.
Okay, with that extension, is that extension included in here? Or would that come back before the Board of Aldermen, the committee?
It would be no change in the amount, so no, ma'am, it would not.
So, okay, so the extension would just be the amount of time you could use it. The approximately $28,000 is the amount of the grant.
Right, so it would just shift those months farther down in the calendar.
Okay, so that we would be in compliance with the requirement.
Correct. Yeah, so they're going to change those dates in terms of the deliverables as well, because you might note that some of those have already passed or nearly passed.
Okay, and so just asking you, would you be the person executing this grant or doing the grant that you're here?
I'll be working with that gentleman from Project Safe, and then we have an epidemiologist, and then of course there's a task force with others who will be doing that, but I will be working with the others on the inside in the health department. Yes, ma'am.
Okay, and who would sign this contract?
Dr. Eccles.
Okay, so for that reason, I'm greatly in support of this contract. I will be voting present for the reason he just gave of the person who's going to sign it. I fully understand a parent and actual authority, but until we get the credentials of Dr. Eccles resolved, then I cannot support that in that way. So I'm glad you're getting it. I think it's a great thing, but I will be voting present. I have no further questions.
Thank you. And as you know, I can't sign those contracts, but thank you very much.
I understand. I would feel much more comfortable if you did, but okay. But it'll come out. Never mind. Thank you. I appreciate it.
Thank you.
Thank you, Alderwoman Tyus. Alderwoman Green.
No questions. Just thank you for coming and presenting this today.
No, I wanted to see how this works. This is a very different way of having.
Can't see you though.
You can see how this works, but we can't see how it's working on your end.
Yes.
Woman Martin, do you have any questions for Mr. Schmidt?
No questions, thank you.
Alderwoman Navarro.
I have no questions, thank you.
Alderwoman Middlebrook. We're going to take that as a no. Alderwoman Rice. Oh, Alderwoman Middlebrook, did you have any questions for Mr. Schmidt?
No.
Thank you. Alderwoman Rice?
No questions. Thank you again for presenting this, Mr. Schmidt.
Thank you for the opportunity.
Alderman Todd?
I don't have any questions.
Okay. Thank you, Craig. You answered the questions I had at the beginning. With that, I'll entertain a motion to put Board Bill 25 before us.
I move that we.
I think we already put it before us, Sharita. We did put it.
You just got to move to pass it.
I'll entertain a motion to on Board Bill 25.
I move that we pass Board Bill 25 out of committee with a do pass recommendation.
Second.
Second.
Sharita, would you please call the roll?
Alderwoman Gracia. I'm sorry, I didn't hear. Alderwoman Gracia.
Aye.
Alderwoman Tyus.
Present.
Alderwoman Green.
Aye.
Alderwoman Martin.
Aye.
Alderwoman Navarro.
Aye.
Alderwoman Middlebrook. Alderwoman Middlebrook. Alderwoman Rice.
Aye.
Alderman Todd.
Aye.
Chairwoman Spencer.
Aye.
Alderwoman Middlebrook.
Aye.
Okay. 1 present and 8 aye votes.
Okay, and with that, Board Bill 25 passes out of the Health and Human Services Committee with a do pass recommendation. I want to note there's been there's been a request to refer to this from now on as the Nacho Bill, and so the Nacho Bill has been passed. The second issue before us is contact tracing. This is an incredibly important issue, and I want to take just a moment to frame the issue here. We know that we cannot maintain the stay home orders forever. We cannot as a city remain closed forever. A vaccine isn't expected by many estimates for 18 months, maybe longer. Lockdown is not only difficult for us socially, but it's economically ruinous. And I want to talk about that side of things for just a moment. I think in order to do so, I'm going to lean on some experts in this field. And I think the chairman of the Federal Reserve System, Jerome Powell, summed things up pretty nicely just a couple of days ago in a speech at the Peterson Institute for International Economics. The speech was covered yesterday by the New York Times, and in Mr. Powell's words, the coronavirus has left a devastating human and economic toll in its wake as it has spread across the globe. As a nation, we have temporarily withdrawn from many kinds of economic and social activity to help slow the spread of the virus. Some sectors of the economy have been effectively closed since mid-March. People have put their lives and their livelihoods on hold, making enormous sacrifices to protect not just their own health, but that of their loved ones, but also their neighbors and the broader community. While we are all affected, the burden has fallen most heavily on those least able to bear it. The scope and the speed of this downturn are without modern precedent, significantly worse than any recession since World War II. We are seeing a severe decline in economic activity and employment, and already the job gains of the past decade have been erased. I want to interject here and say that it's my understanding that 36 million people have filed for unemployment in the last 2 months alone. Back to Mr. Powell's words, among the people who are working in February, almost 40% of those in households making less than $40,000 a year have lost a job in March. This reversal of economic fortune has caused a level of pain that is hard to capture in words as lives are upended amid great uncertainty about the future. So that's kind of the economic side of things. We have, of course, moved to reopen our economy, recognizing that closing it down is not only difficult for those owning businesses, but has really an enormous and unprecedented impact on some of our most vulnerable populations. Here in St. Louis, you know, we are an economy that has trailed our national competitors. We are almost alone in having not fully recovered from the economic downturn of 2008, but we have gained significantly over the last 10 years of economic expansion. Those gains have been wiped out entirely over the last 2 months. As Mr. Powell has pointed out, COVID-19 has a vast impact on our economy, but we also know that it is disproportionately impacting the health and well-being of our low-income communities, workers, families, and those affected by the health outcomes of COVID-19. We know we cannot sustain a lockdown from now until a vaccine, but at the same time, reopening without making sure that we have effective control on how the coronavirus is spreading will not only be deadly to human life as we have seen it, it will also be ruinous, continue to be ruinous for our economy. As infection and mortality increases, if we don't handle the reopening effectively, we'll be forced back into lockdowns, and we will break down the trust of our community, including customers that are out and about now that we've relaxed the stay-home orders. We can't leave this to individual choice. We know the virus is entirely too contagious and can very easily overwhelm our healthcare system. And that's why national experts have been over and over again focusing on the two most important and effective ways of controlling the spread of coronavirus: testing and tracing, contact tracing. And it's our job as policymakers to ensure that we are giving the health department the tools they need, the funding they need to effectively enact the contact tracing that is so vital and so important to being able to reopen our economy and to be able to function again as a community. And with that, I assume that Franda, you will be speaking on behalf of the health department. For the committee members, I did send a list of questions for Franda. I had the great opportunity of speaking with her the other day. I found her to be incredibly knowledgeable. I have great confidence in her ability to communicate effectively what is going on within our health department with regards to contact tracing. And with that, I'll turn it over to you, Franda, to introduce yourself, and we can start going through some of the questions that many of the members of the committee had and we presented you with before this hearing.
Okay, sounds good. Can everybody hear me? Okay, so I got knocked off before, so if I get kicked off, then I'll just call back in. So I just want to apologize in advance in case that happens. So like Alderwoman Spencer said, my name is Franda Thomas. I've been with the City of St. Louis Department of Health for, it'll be 6 years in June. Prior to joining the Department of Health, I worked as a coordinator. Before my stint at Integrated Health Network, I'm actually from New Orleans, Louisiana. I came from the state of Louisiana, where I worked at the state for the HIV/AIDS program as a regional HIV prevention coordinator. And that was before, during, and after Hurricane Katrina. So here I am now.
So Franda, you're heading up the infectious disease, the communicable disease part of the health department, is that right?
Yes, that's correct.
You are really overseeing what we know as contact tracing.
Yes, so it's important to understand that contact tracing is a piece of disease investigation. The concept of contact tracing is not new. Contact tracing goes along with any kind of reportable communicable disease, whether we're talking about COVID-19, whether we're talking about the flu, salmonella, shigella, syphilis, any reportable communicable disease, contact tracing is a function of overall disease investigation.
And so your role in the health department is overseeing that disease investigation unit within the health department.
That's correct. There is a supervisor, and she reports to me, and the disease investigators directly report to her, and she reports to me, if that makes sense.
It does. So then,
okay.
So then your role is to oversee the investigations of all different, in normal times, we are tracing contacts associated with other communicable diseases. Can you walk us through a little bit of what that looks like in a normal non-COVID world?
Yeah, so before the pandemic, I would say that we probably averaged maybe about 30, 40 cases a month, just kind of depending on season, right? Of course, when kids go back to school, you may have salmonella, you may have different kind of disease that are associated with kids, flu season, so you may have a spike in flu. It just kind of depends on what's going on during the year that we'll see different outbreaks, so to speak. And so sometimes you have more than others, but I would say roughly a good estimate on a normal non-pandemic time, we would have maybe like anywhere between 30 or 40 index cases of any kind of communicable disease. Yeah.
When that happens, you are interviewing the person associated with that positive result and understanding the contacts, and then you're trying to triangulate who all has been exposed, and that way you can quarantine or advise and make sure you're educating folks on their exposure to those those dangerous diseases, correct?
Yeah, correct. Again, depending on what the disease is, your measures will be different, right? So it just kind of depends on what it is. It's going to vary depending on what the disease is.
But pre-COVID, how many city employees were doing what we would consider contact tracing for the city of St. Louis?
Okay, so pre-COVID, so there's no specific contact tracing job, if that makes sense. So the job is called disease investigator, but as the city title, it's called health program health rep. So before COVID, we had 3 program health representatives. And those three program representatives do the disease investigation pre-COVID. But we have about roughly 13 public health program reps in communicable disease that have been cross-trained and that are able to step in and assist with disease investigation in the event there's an outbreak, and now in the event there's a pandemic, to assist in those investigations.
And typically speaking, what are those other 10 people in that department doing when they're not doing disease specific to contact tracing?
Yeah, absolutely. Health education, risk reduction. So we do have, we receive funding from the state via the CDC for HIV prevention education. That includes HIV testing, health education in the community about any communicable disease, whether it's HIV, STIs, just a myriad of communicable disease. So mostly education, outreach, testing, community mobilization, those type efforts.
And so during the COVID-19, as we shift into a COVID world, if you will, how many of those cross-trained individuals have now moved over into the disease investigation unit?
Yeah, so we have 10 full-time public health program reps that are actively investigating COVID-19 cases, which include contact tracing.
Okay, so then the contact tracing piece of it would make up about how many of those 10?
So so let me break it down another way. So all of them, so when you have a case, you have what we call, you have the index case. So you have the case, and then when you start the disease investigation process, you ask questions, who have you come in contact with, that type of thing. And that's the contact tracing piece that you're referring to, right? And so everyone who investigate cases does contact tracing. But I think what you're asking, so we do have 3 part-time, we do have 3 staff that help with contact tracing exclusively for this effort. And they work on it part-time. Additionally, we have secured a few other, we have secured 2 WashU third-year medical students, and they assist in a disease investigation, including contact tracing. We also have 4 state disease investigators that have that assist in actual contact tracing as well as case investigation. And they're working on those efforts full-time. And they've been given it to us in kind by the state of Missouri.
And so when we talked last week, it sounds like maybe the state has given us an additional person, or are those the numbers of individuals working for the state helping the city right now, or have those changed?
I think when you and I talked, it was 3, and they did give us another one. So now we have 4. That's correct.
And then, so is that like under contract? Can we rely on those state employees, or are they just sort of lent to the city of St. Louis right now?
So they're linked to us, but they are working on this full time because they've had to pivot as well to help in this heavy lift of the increase in cases statewide in Missouri. So often those investigators, I'm not exactly sure what they are doing in their pre-COVID time, but everyone, including the state of Missouri, has had to pivot. They've had additional disease investigators brought in from other section areas that have been cross-trained as well to assist in the efforts to enter labs, et cetera. So we're seeing that with our partners as well.
Okay. And so it was my understanding when we talked last week that the total number of kind of full-time folks working on this was around 10, working on the contact tracing piece of it. Would you say that's about in the right ballpark?
Yeah, so contact tracing in addition to disease investigate. Yes, ma'am.
I don't want to go down too far in the weeds. You know, there are a lot of questions here. I want to give my committee members an opportunity to ask questions just to better understand some of the components here, because we talk a lot about contact tracing, but there's not a firm understanding of what it actually is. So thank you.
Absolutely.
For outlining the landscape there, Fernanda, and as I mentioned in my email, feel a lot more confident about the program, having talked to you, the woman in charge of it. But that volume is obviously, that's a lot of load for 10 people to be working on. I'd like to turn it over to my committee members to ask questions, and I'll start with I'll go in order here. Alderwoman Ingracia.
Thank you, Madam Chairwoman Fronda. Thanks for being with us today.
You're welcome.
Where do you feel like you have the number of people that you need in order to be able to undertake the work that you currently have or may have in the future?
Thank you for asking that question. So I think one of the things that we have been able to successfully do is that we have cross-trained individuals even before COVID-19, right? And so we've been able to stand those people up, and they've been able to assist in those efforts. Another thing that I think is important to understand is that while these numbers are high, and I'm not telling you that, it's different pieces of it to understand. For example, some of those cases are in congregate living facilities, which means it's not individual residents, nursing homes, rehab centers, group homes. So in that aspect, some of those are kind of more concentrated, right? Because some of those people live there, so it's residential. And having stay-at-home orders helped us, right? Because if it's a residential facility, we were able to quarantine the entire residential facility. And so the footprint was relatively small because no one could go anywhere, right? And so when we, those congregate living facilities give us what we call a line listing. And so the line listing consists of all those people who are at those residential facilities. So we're able to make sure we are able to engage in administration there to make sure they have the proper PPE, assist them in getting testing set up for all residents, not just residents that had tested positive, but any residents who need to be under quarantine as well as employees. There are also stay-at-home orders also gave us the benefit of when we did have people who tested positive, when we're doing those interviews for disease investigation, okay, well, how many people, where did you go, right? From whatever time period is identified from the onset of symptoms. And they would say, well, we have stay-at-home orders. I went just 2 places. And so the contact lists have been relatively short. Now, to answer the second part of your question, do I anticipate a greater need now that stay-at-home orders are lifted? I think that's what you asked me.
Yes.
Yeah. I'm sorry, I'm looking at the wrong person. I'm so sorry.
I couldn't tell.
Oh, okay. Okay, so that is a concern. However, I do have the support of administration. And so one of the things that we do is that we have daily check-ins at the end of the day with administration to discuss any of the barriers that we're going through, any of the outstanding needs, and then also any kind of anticipation. Because one of the things that we do in communicable disease is that we monitor disease, we look at trends and try to anticipate what's to come as best as possible. We also have the support of our partners from the state as well as the county, like, talking about best practices, how are you guys addressing this and those kind of things. So I do know that administration at the Department of Health is willing to bring on additional staff persons. And I do know that they're working on those plans so we can bring in additional to help in the event that we see what we think we may see, which is increasing cases because, the stay-at-home orders have been lifted.
Okay, thank you. That's super helpful. Can you just clarify something for me? So when you say that the health department would be able to provide additional resources, does that mean the state department or the city or both?
Yeah, so kind of a mixture of both. So let me give you a couple examples, right? So in the congregate living facilities in which I spoke about earlier, some of them are state ran. And so what happens is, let's just say one of the facilities is state ran. So we do a conference call with the state as well as the director of nursing or any kind of infection prevention staff. And so then we discuss, okay, we make sure that they have proper protocols in place. They may have needs of PPE. They may need assistance in getting test kits. And so the health department has facilitated that. We have also provided gloves, masks, and any kind of PPE to those places who may have been in need. Education, we've done that. One of the things that we've also been able to identify, unfortunately, especially when we're talking to the contacts, when doing the contact tracing and putting people under quarantine, a lot of people don't have thermometers. Who would have thought that, right? I'm a mom, so I have like 5 thermometers at home, but most people don't. And so we've been able to secure a large amount. Right, we've been able to secure a large amount of thermometers from the supply commissioner. And so when we are putting people under quarantine, we also provide them with thermometers. We ask them, do you have a thermometer in order to check your temperatures twice a day? Because that's a piece of their reporting being under quarantine. And so we actually have identified staff who do what we call thermometer drops. They place them in the mailbox or place them on the door of those residents who are in need of thermometers. We've also done the same thing for congregate living facilities. Not all of them had the infrared thermometers to even monitor those who are under quarantine. We've been able to assist in that. And then also one of the things that we've been able to assist with that I'm extremely proud of is that we have a partnership with Integrated Health Network. Because unfortunately, a lot of people still don't have primary medical care. And so we're doing that contact tracing and having those conversations with people about, well, if you start to experience symptoms, this is what you should do. These are your options in your neighborhood, your FQHCs. And so we're able to make those referrals. And we have an identified person at the Integrated Health Network that will actually warm call, reach out to them and get them established in primary medical care. So that's been extremely helpful as well to be able to offer that kind of resource. Additionally, Integrated Health Network, they have other community referrals at their disposal that they're able to connect as well. Also being able to make some connections with the St. Louis area diaper bank. So we've been able to connect a lot of people to resources throughout the community when we are doing the contact tracing. So that's been a huge resource that we've been able to offer.
That's great. You did, and then some additional really helpful information. So I appreciate that. Yeah. Last question I wanted to bug you with is, can you articulate how you are partnering with other municipalities, St. Louis County, Metro East, just because, we're so fractured and people are going over boundaries all the time and sort of, yeah.
Yeah. So a couple of things. So we, even before COVID, we have our communicable disease section has a very good relationship with St. Louis County. We call them all the time because, as you all know, many people live in the city, work in the county, vice versa. And so there's always been a cross into city county since forever. And so the good thing about it, those relationships are very strong and already established. So oftentimes, let me just give you a real life example. There will be, we'll have a contact or maybe even a case who lives in St. Louis City, but has decided to quarantine in St. Louis County. And so then we'll have those conversations with the county. Hey, just to give you a heads up, you know, this person is being monitored, or this person is a positive case, but they're living here, and vice versa. We have weekly calls that consist of, we have weekly calls with the state, the county, and other jurisdictions as well. And so we kind of give updates on what we're doing, what we're seeing, any kind of trends. You know, hey, this is a particular situation that we've identified in our region. What about you guys? We kind of like swap best practices. The same with Illinois. A lot of times we have cases or case contacts that are in St. Louis, but they reside in the state of Illinois. And so one of the things that COVID has done, it has strengthened those partnerships that maybe didn't exist. They exist now. And so I think that's a good thing. So we'll keep that, because if it's not COVID, it'll be flu, it'll be something else. And so those things have been good to identify.
Great. Thank you so much again for spending time with us and for the work you're doing. I can't imagine the amount of time and energy that you're putting in, and it's appreciated. And please keep the health committee posted if we can be supportive of that in any way.
Thank you. Thank you. I appreciate that.
Alderwoman Tyus, do you have questions for Ms. Thomas?
Yes, thank you. First question I have is, so since this COVID thing is, we've been stay at home, so has most of your contact tracing been that you have telephone, emailed, whatever? It's not, you're not going out to people's houses and knocking doors, right?
No, ma'am, we have not.
Okay. And have you found when you contact people and it's usually, is it to tell them that you have information that they've been in contact with someone who has tested positive?
Yes, ma'am. It could look like a couple of different things. Sometimes we are given the results because sometimes, let me give you an example. Total Access. There's been a couple of times they've contacted us because the person left without getting their results. So we have been in the position where we'll contact the person and give those results. And then other times, a piece of the contact tracing is when we are calling people saying, hey, you've been listed as a close contact of a confirmed COVID-19 case, and we need to put you under quarantine. So it's happening both ways. Yes, ma'am.
Alderwoman Tyus, do you have further questions for Ms. Thomas? We'll come back to Alderwoman Tyus. Alderwoman Green, do you have questions for Ms. Thomas?
Yes, thank you for, sorry, I couldn't find the unmute button. Thank you for coming here today. I have a couple of questions. First off, you know, if we're sort of moving, we've cross-trained people and we're sort of moving people theoretically from other jobs that we need to have done into COVID, what is happening to other like normal caseloads? So, you know, our STD, you know, tracing and education, and can you speak to what's happening to those programs at the moment?
Yeah, absolutely. So we've seen decreases in all of those because, again, the stay-at-home orders kind of halted that. So a lot of people haven't been getting those STD tests. We haven't had any requests to come out and do education and awareness because those stay-at-home orders. However, that's what we have been working and focusing our efforts on to restarting those activities. And so they're going to look different. A lot of things are going to be potentially online. A lot of them are going to move to like appointments. They're gonna look different, and that's something that we're figuring out how that's gonna work out. And so we have been in contact with our funders as well as our other partnering organizations to see. Another thing that a lot of, especially when you mentioned STD testing, a lot of it was a lot of education and outreach that happened in like maybe schools or like universities and those sort. And since those aren't in session, so the requests for those have decreased. But I've been working with staff to see what that can look like post-COVID. A lot of this actually honestly reminds me of Hurricane Katrina, unfortunately. A lot of it is restarting after something major happens. And so unfortunately, I do have experience in restarting programs after a major event like a pandemic and like Hurricane Katrina. So it's going to take us to reassess what the landscape looks like now, because things have changed and changed on every aspect. A lot of people, so we do know that behaviors still happen, but the way, for example, just going into a city building now, you getting your temperature checked, those type of things. So we are sifting through that to see what's our now normal is going to look like, and how we're going to face those.
So I think, part of my concern is, pre-COVID-19, we had some of the highest STD rates in the entire country.
Oh, yeah. Mm-hmm.
And so my concern is, do we really have the adequate number of staff that we need, going forward to continue to handle everything that we need to handle with COVID-19, while also ensuring that we do make a dent in our STD rates and our child asthma rates and all these things that, we are kind of known nationally for not having the best health outcomes.
Yeah. And so one of the things that I talked about earlier is that we have brought those concerns to administration, and it is good to know that they are supportive of us bringing on additional staff so that we can maintain our capacity in our workforce. But something that you mentioned as well, even before COVID, we were looking at different ways to address those other communicable disease. Even before COVID started, the new thing was to look at home testing, right? And to see what that looks like. And so post-COVID, that is like, okay, we started these conversations before, let's bring them back to the forefront. A couple of organizations that we currently work with are doing some pilot studies on those at-home testing for STIs. And so I think that that's what we're going to see in the future. And I think that's something that the health department is going to invest in as well. But you're absolutely right. We are going to need to address those issues, and the administration has given us support that they'll make sure that we are able to address those issues with capacity of the workforce.
Have we started the hiring process for new positions, or do we have a timeline on when that might happen?
So I'd have to follow with administration. I do know that we do have a couple of positions, particularly in communicable disease. Then I think the rumor was that we were in a hiring freeze, and I don't really want to speak on that because I'm not really completely sure, but I can follow with administration on that.
Okay. And then other question I have is, I've been contacted by a lot of constituents who work in healthcare fields, have, varying degrees of kind of expertise about, whether the health department needs volunteers to assist in these efforts. And so could you speak a little bit to that, and if that is a possibility, or is it in the future a possibility for people to kind of lend their expertise to helping you?
Yeah, and first I want to say I love volunteers, and we love volunteers at the health department, and we have been fortunate enough to have quite a few. We've had a couple when COVID first came, and we initially started the call bank. And we were getting blasted with calls daily because at first it wasn't a lot of information out. We were able to bring in volunteers that were retired doctors to answer the provider line. And volunteers have been extremely helpful, as well as those medical students who have been extremely knowledgeable. Those third-year WashU students that I spoke about, those came from a referral from Dr. Will Ross. They have been awesome, being able to hit the ground running. To not only work cases, but do contact tracing. And they don't mind working after 5 and coming in on Saturdays and Sundays. So it's been phenomenal to have volunteers. So absolutely, the thing about it is what has been most helpful to us is that the volunteers that we have been able to attain through WashU or even through SLU, because we also have 4 SLU DOH interns that are paid through the Department of Health right now, that we're training this week in contact tracing. So what has been extremely helpful is to have those volunteers to come on. So absolutely, we will look forward to engaging volunteers, but I think we also need to be intentional with their time and also with the effort, because a lot of the work in the contact tracing does require some skill. And I'm not saying that people can't be trained, because they absolutely can, but it's just a little bit more in depth than calling. There's some, there definitely is some training that takes place. And then also keeping in mind that we are still practicing social distancing ourselves. So one of the things that we've done at the Department of Health, we have staggered shifts. And then we also, so with the staggered shifts, so we're not all bunched up at one time. And so that's one of the things that we've done with those students and volunteers that we bring on, that we bring them in like kind of like off peak hours, so that we can decrease the amount of people that are actually in the office space at one time.
Okay. And if we have folks that approach us about volunteering, who is the point person that we should refer folks to?
I definitely wouldn't mind getting those emails or those. Yeah, that would be fine.
Wonderful. And then last question I have is kind of about antibody tracing. So some of the urgent cares I know around here in particular have started doing antibody testing, and is the city also following up on positive results from those antibody tests, and what does that process look like?
Yeah, so what happens is, so the anything reportable, whereas the antibody test, whatever test, it goes directly to the state lab, right? And so when the state lab gets it, whether it's a probable antibody, whatever kind of test, even inconclusive, and inconclusive is like, let's just say, for example, the test was administered incorrectly, didn't have enough specimen, whatever the case may be, they don't have an actual result. We follow up on every last one of those cases. And so it just depends on what the result of those cases, what it is. For example, if it's an inconclusive test, then we encourage that person to get retested. And so we follow up on any of those, any result that we get, we follow up on those tests. And we do contact tracing as well on those. So absolutely, we get those reports and we follow up.
Okay, thank you.
Well,
I think that is all of my questions for now, but thank you so much. And I'll be sending some volunteers your way.
all right, cool. Thank you.
Alderwoman Martin.
Excuse me, I'm back on again. I've been back on. I had to go out and come back in. I would like to finish my question.
Yes, ma'am.
Alderwoman Tyus.
Okay, thank you. So I couldn't hear your last answer, but my next question was, what is the time frame from when you get, when you gather information and you discern that people need some kind of help? What's the kind of turnaround that you're able to get help to them?
Yes, ma'am. And so just so I'm clear about your question, when you say help, you mean like you talking about beyond COVID, like resources, or you mean
like resources? Like if you say you determine, oh, they need thermometers or they need whatever. Okay, what's that turnaround time like?
Less than 24 hours. Sometimes we're able to go out the same day. Just depends on when we actually make contact. Some people will say, you know, you don't have to come and bring out the thermometer. Can you meet me downstairs with it? We've done that as well, because those are people that we want to monitor. So the sooner we can get you that thermometer, the better.
And so if there are people who have resources, do you have a list of things you may need, or is it the city purchasing this, or where are you getting these resources from?
Yes, ma'am. So the city has purchased those thermometers for us through the supply commissioner. Okay, so is there something that you are running short of that you may need, or that someone could donate? I would think so. So I'm just saying, if you had a list, let's just say it's not, okay. If you say, well, we're really running short of masks, or we're running short of this, and somebody knows where we may get some, then where would they donate? Would you be the contact person? I think so, but I can double check with the administration to see if there's a better source for that. I can check with emergency planning and see that. I think maybe they're probably the most appropriate person, and that would be Justin Hauser with emergency planning. Yes, ma'am. Okay, and so are you having any pushback from the people that you reach out to that don't want to accept what you're telling them? Yes, ma'am. So unfortunately, unfortunately, there is still a lot of stigma with any communicable disease, right? So there have been times where there have been contacts, or there have been cases, and people say, you know what, I really don't want to give you a list or give you a name of anybody, for a couple of different reasons. I know that I've had one person to tell me, you know what, I know that this person cannot afford to be out for 2 weeks under quarantine. They'll lose their job. Or we've had people to tell us themselves, I'm not sure how this is going to go over with my employer. There's still a lot of stigma, unfortunately, pretty with a lot of communicable disease. And so, yes, we have done that. Or some people don't have, unfortunately, and some with good historical reason, don't have trust of the government. And so I don't want to give you the name, or, you know, or they have, or they don't want to talk to us. So we've run into that as well. Yes, ma'am.
And so I don't think legally right now, you don't have any legal options to make them tell you the names. So how is it that you usually handle that if the people don't want to give you names?
Yeah, so if they don't want to give us names, then the best that we can do is we can try our best to pull together their own footprint. For example, if we know their employee, if they just say they worked at a pizza parlor, then we can contact that location and say, hey, you had someone who tested positive. Can you assist us in giving us some information of some of your other employees, so that people just to be on the lookout if they start to feel ill, you know, that these are the things that we're supposed to do. So that's when our investigation piece goes into way, and we try our best to follow up on what information that we do have available to us.
Okay. And is there anyone you are legally required to tell if you find out someone is tested positive? Is there anyone on the, say, I'm going to use me. You find out Sharon Tyus is tested positive. Is there anyone, if I worked at a nursing home, would you be required to tell the nursing home that one of their employees has tested positive?
We absolutely will do that, because the nursing home are a most vulnerable population. So we will say that you have an employee who tested positive, and we're going to have those conversations, and we're going to absolutely put that nursing home under quarantine and make sure they have the infection control measures in place. Yes, ma'am.
So what if I don't want my name to be given out?
Yeah, we won't give out your name. We won't say Sharon Titus. We will say an employee. That's correct.
Okay. But by process of elimination, they're going to probably figure out pretty easy, you know. Right. Okay. And so you will put them under quarantine. I have several people who I own apartment buildings, and I have several people who are nurses, but I also have people who are healthcare. They take care of people. They go to their houses. So what do we do when those people test positive? Do we then have to track down who they're taking care of? Because they may have 5, 6, 10 clients or something like that. How do we handle that?
That is exactly, that's exactly what we do. And that we've had that case before. We had, I think she was, if I can recall, she was a traveling nurse. And so we absolutely would track down those patients that she had been caring for. Yes, ma'am.
Okay, and then do we put each of those patients in quarantine?
Potentially, because you have to identify, so it depends on when the onset of her symptoms were, and it depends on how much contact she had with that patient. And of course, I mean, if she's caring for him, I would assume that it's a close contact, and she's probably been in contact with them for 15 minutes, probably a couple hours. So yes, ma'am, we would.
So then my question becomes, so if they're in quarantine, who takes care of them? Is it that same person, or how do we deal with that?
No, we would need to put that person, they would need to separate, and then we would work with them to get some alternative measures, because they need to be under quarantine and they need to be isolated as much as possible. And we would assist them in working that. That actually brings me to one example that we had before. There was a senior living facility, and it was they didn't provide any medical care because they could live independently. And one of the persons that we put under quarantine, her granddaughter was taking care of her, but she needed to be under quarantine as well. And that was the real concern. She was like, well, my granddaughter is the one who comes in, prepares my meals. She comes in and on and so forth. So we were able to work with her to identify another person to assist, because that person did need assistance in getting some of the needs met. And so we decreased the amount of exposure as much as possible while being under quarantine, but we were also able to facilitate some home delivery meals. So nobody needed to be there to actually prepare meals. We exhaust all options to get people assistance, because we try our best to exhaust all options, to decrease exposure and to give people the resources that they need.
Thank you so much. I don't have any further questions. Madam Chairwoman and members of the committees, I have another commitment. So I do appreciate this conversation because I always wanted to know how that worked. And so this has really helped clarify a lot of things to me. So Madam Chairwoman, thank you for having this meeting and adding that to the agenda.
Thank you, Alderwoman Tyus, for your thoughtful questions. Alderwoman Martin.
Thank you. And Ms. Thomas, thank you so much. This has been really helpful. I think there's some information that my colleagues and I have been seeking, and I've had a ton of questions answered already today, and I feel much better about where we are in the city. Just kind of, and you're talking about connecting folks with resources, and I just wondered if there are any major holes in the resources that people need right now where we could be helpful. So like you mentioned, the diapers and that sort of thing. Is there just kind of that obvious missing resource out there where we could be helpful?
Yeah, that's also been a thing. And then unemployment. I mean, I know a lot of people have unfortunately lost their job. Alderwoman Spencer painted that picture before the conversation, so that's been real. And then especially when we're dealing with a lot of the congregate living facilities for the elderly population, we have partnered with Human Services, so we're making sure that like they're able to get home delivered meals. So those kind of things are usually the things that come up. And then also, like I said, getting people established in primary medical care. Those are the things that usually pop up the most.
Okay. I would assume with the home delivered meals, that's something where some of that HUD money will play in. I don't know. Okay. All right. And then also, I know, I forget which colleague asked, do we have enough? I think maybe it was Alderwoman Green asking, do we have enough contact tracers? But let's just say perfect world, would we hire a lot more, or do we feel confident where we are? I know we are comparing ourselves to other places, so it's just hard to gauge. In a perfect world, do we need 100 more, or are we okay for now?
So my response would be for May 19th at 2:09 p.m. We are okay right now. However, we are, kind of, since stay-at-home orders were lifted just yesterday, we are being very watchful of what what may come as far as increase in cases, and to see what that can look like. So we are poised and ready to bring on additional staff, even if it's in an interim or a part-time capacity. The administration has let me know that they are open to that as well. So that's reassuring. But as of right now, today, I feel like we're in a good place. But I also feel like those needs could change.
Okay, great. Thank you. And it was very nice to meet you virtually.
Very nice to meet you as well. Thank you.
Alderwoman Navarro, do you have any questions for Ms. Thomas?
Yes, thank you. Thank you, Ms. Thomas. I also found this very informative, and I'm really grateful for all the hard work for everybody in your department. I know a lot of us are, it's just affecting people in different ways. And I just get the sense that you all are really scrambling and working really hard during this time. So thank you. I just, there's a couple of questions, and I guess part of it is just reiterating that I'm with you in that I think that as we open up, the number of contacts that any infected person has been going down because we've been staying at home. And so that number is going to go up. So it really just seems like the number of contacts that people have is going to go up. And then, tracking those people down and being able to keep track of all of this is just going to become a bigger and more daunting task. So I think hopefully you're hearing from us that we want to support you all in getting the resources that you need. How obviously getting paid trained staff is the best if we have to rely on volunteers. Again, I'm just echoing what many of my colleagues have said, is that we see that there's going to be an increased need here, and we want to help you out. I am curious a little bit about the any new technology that we're using. And I mean, I know Dr. Eccles has referenced an app that when somebody tests positive, it sounds like they bring that home. And I understand that they input their temperature for that. If there's anything else you can tell us about that, or any other new systems that are in place in terms of being able to track people. I know that's something the CDC has advised cities to be doing as well, and health departments to be doing too, is adopting new technologies so that we can better be able to track all of this.
Yeah, so right now, currently, we have what's called Qualtrics. And so it's a software system that when we are doing that contact tracing and putting people under quarantine, so it is it is an app. But what happens is, first of all, let me be clear, everyone that we get in contact with, they have to agree to it, because we need their email address and we need their phone number. And so they can get it one or two ways. So it's very short. I think it's less than 5 questions. One question is, what is the highest temperature this morning? What is your highest temperature today? So they get that email or that text around 7, and they have until 9 to make their response. It'll also ask, how are you feeling? What symptoms are you experiencing? Check all that, apply. And then there's also a space for free text. And so in that free text, they can say, not having any of those symptoms, but I'm experiencing X, Y, Z, and they can free text whatever that is. And so it's set where any alerts, like any temperature that's over 100, it'll send us an alert and say, Ms. Navarro is experiencing a temperature of 102. And so then that will alert us to give Ms. Navarro, to give you a call and say, notice you had a temperature of 102, what's going on, or to connect you with medical care. So they will get that twice a day, because we ask people to monitor their temperatures twice a day, the morning and the afternoon. A couple things we found out, although it's 2020, some people do not have emails. So everyone is not reported in Qualtrics. And those people who are not, we actually call. And so another thing that we found out in a lot of the congregate living facilities, particularly those retirement communities or nursing facilities, a lot of those individuals who probably, I would say maybe like 65 and up, none of them had emails. And so those were actually calling to get those temperatures, to get that information. So Qualtrics is one of them, that one mechanism that we use to monitor. That's one piece. But you asked about any new software. We actually did have a demo with Qualtrics, and it's a very nice package that will give us even more of a robust system now. Because that's the contact tracing is one piece. There's also a lot of paperwork that's associated with working cases. It's called a PUI form that goes to the CDC, and that's where they can that asks like more detailed question. Was this person hospitalized? If so, what is more detailed health assessment that we fill out on every positive case that gets uploaded to the state that goes to the CDC. So this particular new piece of software from Qualtrics, we can tailor it to ask those questions that are on PUIs. They can do a lot of GIS mapping. It is beautiful. It does come with a very pricey tag. And so giving that information to Dr. Eccles, and hopefully we'll be able to get that, because I do think it'll be worth it, beneficial, not just for COVID, but also long-term, because even after COVID, we still have TB, we still have everything else that existed before COVID. And so hopefully those type of investments in software we can get, and that'll bring us to COVID and then beyond.
Great. And how many people are logging onto the Qualtrics app on a given day?
So that's the number that's being reported that you see. So like right now we have 65 that are actually doing it. And that number is going to vary because people's quarantine times depend. Some people, you may not feel like responding to it today, so you didn't respond. And I get that alert as well to follow up and say, hey, I've noticed that you haven't responded. Is everything okay? And that allows us to get some kind of follow up. The good thing about Qualtrics as it stands right now, it frees up a lot of manpower that would otherwise have to happen with us actually cold calling, a congregate living facility to get 65 temperatures twice a day, that type of thing. So it has definitely been beneficial, but just demoing that shiny new package, I'm interested.
Great, thank you. And so once somebody is using Qualtrics, well, whether they're using Qualtrics or you're calling them, how long are they monitored for? Like, at what point do we say, okay, we're done monitoring you, go on with your life?
The longest is 2 weeks.
Okay, so nobody's beyond 14 days. Okay.
No, not unless you're if you're a positive case, you have to be medically cleared. But if you're just a contact, it's 2 weeks to be under quarantine. Okay.
So, and I'm not saying this is the number, but if it's like 65 people or, well, maybe I shouldn't just ask about Qualtrics, but I guess so the number of people we're monitoring, that's the number of people we believe have been in contact with people who have tested positive.
Okay. Yes, but that is those who have agreed to be into Qualtrics. It does not include any congregate living facilities. Because
yeah, gotcha.
Right. Okay.
Okay. I'm just trying to get a sense, and I'm sure like you all are too, especially as we open up, like what is the community of people that we need to be monitoring on any given day? And it just seems like it's much higher than, than we're able to monitor right now, or that we're aware of.
Yeah, so one of the things with the congregate living facilities, they monitor, that's why the important relationship exists between the director of nursing or the occupational health or the medical director, because they provide those line listings, and then they also quarantine those facilities. And so we assist in that process. And so those are being monitored by that facility, if that makes sense. Because they're residential, they can provide a more skilled assessment on a daily basis.
Got it. Yep. Great. Thank you very much. I don't have any further questions.
You're welcome.
Alderwoman Rice, do you have any questions for Ms. Thomas?
Sure. Thank you so much. And thank you for taking all of this time with us. My colleagues have asked great questions as well, and ticked off a lot of the things that that I had for you as well. And specifically the Qualtrics software is something I think that we were all very curious about, because it had been some type of new technology had been referred to multiple times on calls, but we hadn't gotten an explanation of what that really is. So that's very helpful to understand, and particularly to take all of that, a significant chunk of work off of the actual staff time load there. So a couple of questions about compliance. Like, is there somewhere that this data is publishable, because we can talk about, most people will comply with Qualtrics, or most people will respond, but what do those percentages actually look like, right? Like, how are we measuring whether or not the software is as effective as it needs to be to address what we're currently seeing?
Yeah, I'm sure that we could get some data for you. I just don't have that information with me, but so what happens is at the end of each day, we get the results of Qualtrics, so to speak. And so it'll give me this is how many people responded, this is how many people didn't, and then these are the free text comments. First thing that comes to mind, yesterday there was a comment, somebody said that they had itchy lungs. So then I would follow up with that person and say, tell me more about your itchy lungs. What does that mean? So it's an extremely useful tool, because like you mentioned before, it chips away some of the staff time that you would have to take, but then also it kind of allows some people don't want to talk to us. Some people prefer, being able just to do it from their phone or their email and just say, I'm feeling fine, it's good, I can't wait to get off quarantine, y'all bother me too much. They say that as well. You know what I mean? So that allows us to do that. But we probably could I'm sure I can get back with you. I can speak to the epidemiologist who runs the Qualtrics program to get some data for you. Just let me know exactly what you are interested in seeing, and I'll make sure that you get that.
Sure. Yeah. And I think, none of us have gotten a full epidemiology course here as we've gotten started, and we're trying to funnel the questions that our constituents ask us and back and forth. And so any of the information is great. And particularly, so you mentioned that number of people being monitored. So those are the folks that you're saying are active in the Qualtrics system on any given day as they get reported to us every evening?
Correct. And that number is going to always be fluid, because some people's quarantine periods end, and we get new cases, we get new contacts. So that number will be fluid based on current caseload, current activity, several different things.
Okay, and so there have been times where there have been far fewer people being monitored than new cases get reported the next day, for example. Can you speak to why that would be?
Yeah, because it's one thing to remember that that does not include congregate living facilities, right? So by definition, those are considered as outbreaks. So let's just say congregate living facility A has a census of 75 people. And of the 75, they may have 40 cases confirmed positive. Well, that means we are putting that entire facility under quarantine and being monitored. So those numbers are not reported, and that those are congregate living facilities. So that's a difference, and that's something that that you should definitely keep in mind. So far, since we started in, I think St. Louis got its first case in March, the city, we have 19 congregate living facilities that have had outbreaks. So those numbers are of those monitoring for those congregate living facilities are in the thousands.
Okay, that's incredibly helpful. And then as far as, so I guess I'm trying to get a picture of how this works going forward. So a new person comes in, tests positive, and then they get in contact with the health department, and the health department says, okay, tell me who you've been in contact with, right? And like you said, that's a whole lot easier when nobody's gone anywhere. But once people are out moving around, is our system entirely dependent on self-reporting of where they've been and who they've been in contact with?
Yes.
Okay,
Yeah.
so and the more we open this up, the more chances that people have been in contact with other people have been, in restaurants and grocery stores and things like that with unknown folks that they've come in contact with. Like, the sort of more exponential this can get, right?
Yes, and you bring up a very good point, and you actually you remind me of a good sale for the Qualtrics demo. So one of the pieces in the Qualtrics demo I referenced earlier has that GIS piece. So let's just say you said you went to Walmart, but you had on a mask, other people had on masks, but you were in Walmart and you were in a line. It will map that Walmart, right? And it'll say, okay, this is the footprint of Ms. Rice. This is where she went, this positive case. And I see a lot of possibility with that I can see a lot of education. I can see a lot of, just awareness to people knowing that, hey, large amount of people who have tested positive shopped at Walmart. I don't want to put Walmart on black, but you know what I mean?
Sure.
Shopped at this location and that type of thing. And because I think that's what you're getting at, because you are right. We are dependent on people telling us where they went. And then oftentimes some people aren't very good historians. Some people say, well, you know what? I did go to the barbershop. I wasn't there very long. I didn't talk to anybody. Or did I go to the barbershop? I did, you know what I mean? So those type of things, that's an absolute real scenario. You are correct.
Sure. Well, and especially with the characteristics of this particular virus, that folks can be non-symptomatic or asymptomatic when they're moving about and still be contagious. I imagine that's a pretty significant challenge for your folks trying to go back and trace all of that together.
Yes.
Okay. So I guess I'm seeing, like, any more advocacy that we can do for you to get fancy technology, I'm here for, because I think that's our best data going forward. But I also, like, I'm seeing an exponential need for human bodies and people doing that work as well. And I'm I kind of agree with my colleagues as we look at other cities, and they're expanding their workforce on this and ramping up ahead of time rather than maybe responding to an outbreak. Is that, I guess we're just trying to figure out how we can best advocate for your department and for our cities so that we get the best health outcomes possible here.
Yeah, to be honest with you, I think this is extremely helpful. This platform has been extremely helpful, but then also the administration has been supportive and has done so. Also, our Board of Health has been extremely helpful as well. Like I said, Dr. Will Ross made that connection with me to Washington University with that administration to say, hey, we have these third-year medical students that are ready to stand up right now. I just got an email before I came here from that contact saying, hey, I have 5 more that are ready to go. So we're going to get them trained next week. So that has been helpful. And then also, again, like I said, we've been able to identify the needs, bring them to administration, and then they've been able to say, okay, this is what you guys are going to have. A lot of things have already taken place. Like, for example, every investigator didn't have a laptop or hotspots at first. Those have been supplied to us. And that definitely assists a whole lot, especially when trying to be socially distant and still do the work. So that's been helpful. Another thing, the mayor allowing overtime pay for staff, because this burnout can be very real in this. And so having the mayor allow us to get paid overtime has been extremely helpful. So that's been most appreciative. And so I'm hoping, so I do feel confident that administration is going to support our us being at full capacity, not only, in anticipation of what we think is going to happen since stay-at-home orders are lifted, but also long-term when flu season is coming up and on and so forth. Yeah, so I definitely appreciate the support from you guys. I really appreciate this.
Great. And then that kind of brings me to another question in that, sorry, my brain is doing that mid-afternoon thing here. Where was I going with this? I might come back to this. I might just have to, I might have to think about it and talk to you again. But thank you so much for all of the information and for just helping us understand how this works and what we're looking at going forward as well. So thank you for all the information.
And I'm more than happy to come back at any point. Alderwoman Spencer invites me back.
Great, thank you so much.
Mm-hmm.
I'm sure we'll have you back, Ms. Thomas. Alderman Todd, do you have any questions for Ms.
Yes,
Thomas?
yes, I want to know if I meet with a group and say, for example, a block unit, for example, and someone in that meeting tests positive, would I have to be quarantined? Would I need to be
Yes, sir. Well, it would depend on a couple of things. It would depend on how close were you in the time frame. But if it was a meeting, I would assume that you're in close quarters with that person. So I would say you would need to be quarantined. Yes, sir.
Suppose I meet with an individual and if they don't have a mask, I take a mask and then make sure I'm 6 feet away from that individual. Will I have to be quarantined if they test positive?
So if you were 6 feet away and you had on a mask.
And I took a mask and insisted that that person wears a mask too before I meet with him or her, would I have to be quarantined then? If I made
right, by definition, you would not need to be under quarantine.
If I attended church and we had 6 feet, there was 6 feet between us, and someone in the congregation tested positive, would I have to be quarantined? Would I need to be quarantined?
No, not by that definition, no.
Okay, then thank you very much. And I'm 100% in support of making sure we all stay safe.
Thank you.
Thank you, Alderman Todd. Thank you, Ms. Thomas.
Chairwoman Spencer, I'm sorry to interrupt. I remembered my question, if it's okay if I could ask one. Would that be okay?
Go ahead.
Okay, sorry. Thank you so much. So my question is our testing scheme going forward, our strategy going forward. So we've worked on reducing the infection factor of one person infecting one person or less than one person in order to try to decrease the amount of infections that are present in our population. So, and now we have more tests available out in the community. We have these antibody tests that people can go and get if they want to go and get them. Is there an overarching testing strategy in the city that is going to say, okay, we're going to work through these specific places, test everyone who's here and, start combing our way through our population so that we have a real grasp on where the infections actually are and you know what I mean, get a whole handle on that? Are we at that point yet? Are we close to that point, or what does that look like?
Yeah, so I would say, like, right now, I don't think that we're at that point right now. Well, as anything that we do with the health department, we're guided by CDC. And so any testing that we do is definitely by CDC guidance, and which filters in for us through the state. And so that's how that process goes as far as who we're testing, how we're testing, and those sort of things. I do think one of the things that has been extremely helpful is to have more testing that's available throughout communities, because that was at first when we had the call bank, that was everything. If people wanted to know, where can I get testing and why was it so difficult to get testing? So I think that we've come a long way. I do think that there's more ways to go. And so that's what guides us as far as the testing guidance from CDC, and then also guidance from the state. That's what we're following.
Okay. And so people are just self-reporting on testing right now. We're not saying, okay, I mean, if people are being contacted because they've been in contact with someone who has tested positive, then obviously we're encouraging them to go get tested. But as far as the antibody test, that's entirely self-motivated for people to go and do that kind of thing. Are we collecting that antibody data back to the Department of Health as well? Is that getting wrapped into what we know about where the virus is?
Yeah, so yes, to answer that question, we do get all that data because we do get those testing results, but that goes because they have to report directly to the state. So we get that information based on the state. I'm not sure that we're using the data in the way that you just described to let it, like those kind of trends. I don't think we've looked at it that way just yet.
Okay, all right, thank you so much.
You're welcome.
I want to take just a quick break. Thank you, Alderwoman Rice. And we'll have another opportunity to ask a couple more follow-ups of Ms. Thomas, but we have an expert here that's been so patient, sitting on the line, Bert Malone, who can kind of speak to, one of the things we have talked about and we've heard a lot, we mentioned NACCHO earlier today, coming out with national recommendations on the volume of testers that we need to have present. There's a pretty well established guideline of 30 tester contact tracers per population of 100,000. That would look like 90 contact tracers for the city of St. Louis, and how we're able, there's a art and a science to contact tracing. We need to kind of talk through some of the specifics and some of the national best practices. And I'd like to bring up Bert Malone to kind of speak to some of that. Bert, if you don't mind, you've been so patient here with us, calling in from across the state. Would you mind introducing yourself and kind of helping us understand who you are and the position you have held in the past, you hold, and kind of what credentials you have?
Thank you, Madam Chair and members of the committee. I am Bert Malone, and I'm here today representing the Missouri Public Health Association, which is the largest voluntary public health professional organization in the state. And prior to my work with MPHA, even though I've been on the board for 25 years, I was deputy director of the Kansas City, Missouri Health Department. So, and I started out actually doing contact tracing, actually recruited in St. Louis and to work for the Centers for Disease Control, which I did for 15 years, moved all around the country from St. Louis to Saginaw to Miami to Baltimore to Jefferson City, all in 15 years. And then got tired of moving around and stayed with the state health department in Missouri, and then ultimately landed in Kansas City when our daughter married a fella up here and we wanted to be near those grandkids. So long story, but it has bearing because my background was in contact tracing, mostly in sexually transmitted diseases, particularly syphilis. And but the principles of contact tracing that Ms. Thomas did an excellent job. I want to commend her and commend the city for having a professional and public health professional of her caliber to help coordinate this activity. So my congratulations to her and to the board, to the committee, for having this level of interest in this particular topic. Suffice it to say that I think contact tracing is the key to managing, mitigating, and controlling the outbreak that we face now. It is essential in every disease. And Ms. Thomas did an excellent job in articulating that there are many communicable conditions that require contact tracing. Chairwoman Spencer mentioned the estimator, if you will, that is published by NACCHO, the National Association of City and County Health Officials, who contracted with George Washington University to conduct an evaluation to allow communities like St. Louis, like Kansas City, where I'm currently volunteering as a contact tracer, to estimate what the number of tracers they're going to need. And as Alderman Spencer indicated, that number, depending on how the community is structured and how the assignments are given, that could reach approximately 90 for a city the size of St. Louis, with some of the risk factors and access to care and poverty elements that St. Louis and Kansas City frankly face. We are now the source to the funding for much of that is going to be the CARES Act that many of the communities will be recipients. Kansas City hasn't received those dollars as of yet. We're negotiating with the counties surrounding us because we were not of a sufficient population to qualify for independent funding. So we're working with them, but we expect to have at least right away 30 contact tracers, but we'll be expanding that, I would imagine, depending on the morbidity. You are very correct in saying that it has been, and I'm not saying the job's been easy, Ms. Thomas, to this point, but as you open up, things are going to get extrapolated to an extent that it is going to be much more challenging than what it has been. The convenient thing with this so far, and I can speak from personal experience with this, with COVID, is that, you know, folks are home, folks answer the phone, folks respond to emails, but once they're out and about, that is not always going to be the case. And their circle of contacts is going to be much larger. So I think you're doing the right thing of having this hearing and educating your committee and educating the rest of the board that this is just, you know, the tip of the iceberg, I expect. And you're going to be dealing with this for quite some time until we have a vaccine, until we have a therapeutic agent. And contact tracing is the most effective, and testing combined with strategic testing are going to be the most effective tools that you have in your toolbox. So again, my congratulations to Ms. Thomas for coordinating a program like this. I did want to add one thing about volunteers, and I think she's correct in saying how valuable third-year medical students have been and will be. The challenge is they're going to come and go, and they're going to have exams that they have to study for or prepare for. You cannot build a program on volunteers. You're going to have an investment of staff to, whether those are independent contracts or limited term contracts. Clearly, this is not going to go on forever, hopefully. And the other part of that is, even though you've got 10 or 12, 15 individuals that might now be reallocated to working this, if you face an outbreak of syphilis in St. Louis, or an outbreak of Shigella, or an outbreak of cryptosporidiosis or whatever, which occurred during the summer, those folks are going to have to deal with those outbreaks, and you're going to be behind the eight ball and needing to recruit and hire and train individuals immediately. So my advice and the advice of the Missouri Public Health Association would be to try to get the resources available from the local government to allocate towards reaching a number of contact tracers that will help you control this outbreak.
Thank you, Mr. Malone. Can you, I want to make a caveat to that. When we looked at the estimator that you all sent yesterday, it was so helpful, and I'll send that to the committee to look at what those national recommendations are. The 90 came from the NACCHO guidelines in a general sense, but the estimator, based on our poverty rates, our infection rates, which are higher than national average, and the transmission rates, which St. Louis City has a higher transmission rate than the national average currently, puts us at 64 per 100,000. So well over 190, I think, estimators would be.
Much as 194. I think.
194. Yeah. So what we're looking at as far as a need of staffing for that varies from anywhere between 90 and 194, depending on kind of how that plays, how these things will play out. And I did, at your advice and your connection yesterday, talk with Dr. Archer, who currently heads the Kansas City Health Department. And they are in the process right now for the Jackson County portion of Kansas City, which is about the same population as St. Louis City, around 300,000 people, currently in the process of hiring 100 contact tracers to kind of anticipate what you described as, that as we open up, it becomes a lot more complicated. Ms. Thomas has outlined that it gets very, very, very complicated as soon as people start leaving. Mr. Malone, do you have any, as far as reporting goes, can you speak to some, I know we haven't had to do contact tracing reporting really because we haven't had this level of interest in the job that that department has been doing for us for so long. But as far as the reporting, traditional reporting goes, can you speak to that? I know this is maybe catching a little off guard, so.
Yeah, many specific conditions have standards for follow-up and quality standards for the effectiveness of your disease control programs, whether it's the number of contacts elicited and found and the period of time in which those contacts are identified and located and tested. Those are all pretty well established for syphilis, for tuberculosis, for other conditions. And I don't know any specifically for COVID yet. I know that there are cities that are looking at that right now, San Francisco particularly.
As far as reporting the tracing, we've asked so many questions, and I think if we had some level of reporting to absolve Ms. Thomas of having to come before us regularly, how many of the 1,694 positive patients have been traced initially, follow up, how many are in that 64 number of currently quarantined. Something that concerns me is just that number 64 being monitored being so low compared to that 30 per day average we're seeing of infection. I know for kind of thinking through what that looks like, you would be monitored for 2 weeks. In theory, every COVID positive patient would in theory have at least one contact. They got the disease, so they've had some level of contact, hopefully. But to to Ms. Thomas's point earlier about those facilities kind of not being in that number, but including that in some kind of reporting mechanism, so we can gain confidence that we are monitoring the volume of people we need to monitor.
And I have not seen that as of yet, but I am confident that the Centers for Disease Control is developing those standards and what the expectation would be for number of contacts per person, per index case, et cetera. So I'm certain that that's being developed. And we can probably glean it from the city of New York or the city of San Francisco that have already embarked on a comprehensive contact tracing and interviewing program, so as well as monitoring. So
I want to open up just an opportunity. I know we've already been on this call for almost 2 hours here, but if members of the committee do have questions for Mr. Malone, who's been so generous to give us his time here and his experience, I'm going to open it up first in the order we have of seniority. Alderwoman Ingracia.
Thank you, Madam Chairwoman. And Mr. Malone, thank you so much for spending time with us. This is, I guess, a tough question to ask because I'm not trying to put anybody on the spot, but in terms of, what best practices are and what you've mentioned in terms of contact tracers, it seems like we're lacking in planning in the city. And that doesn't speak, to what Ms. Thomas is doing, which seems like an incredible amount of really impressive work. But how do you see your role, if there is one, in helping advocate for a better plan for the city of St. Louis if we're not able to do so from a political standpoint sometimes?
That's a role that, it's a very good question, thanks. That's a role that the Missouri Public Health Association can play and has played in I'm not going to say we're lobbying because we're not supposed to lobby, but we definitely are. And as the city is a public health agency and is facing a public health epidemic, it is the role of the Missouri Public Health Association and all professional organizations concerned about health to advocate that they get the resources that are necessary to carry out their duties. And we have done that with letters to Governor Parson, to Director Williams at the State Health Department, to assure that resources are going to the local health departments to assist in this regard. There are some local health departments in the state that have clearly had a handful of cases, and that's it. But then you've got the city of St. Louis and St. Louis County that have had significant, Kansas City that have had a significant number. So we feel that it needs to be need-based, but our advocacy efforts are not going to be minimal. We are on the phone with advocates throughout the state on a regular basis, and we'll continue to do so. So we'll work with you. We'll work with Dr. Eccles and others across the state to get the resources that you need.
Great.
The state in the first allocation of resources did not go to the local health departments. It went for PPE, which I agree is definitely needed, but you know, we think the local health departments are, if not the first line, they are a front line in the defense of the public.
Okay. Yep. Thank you so much. Yeah, we want to make sure that Ms. Thomas and her staff are receiving all the resources and support that that are available. So I appreciate that. No further questions. Thank you.
Alderwoman Ingracia. Thank you for that. Alderwoman Tyus, are you still with us? Alderwoman Green? Or Alderwoman Green?
No questions, but I do really want to thank you for chiming in today. Some of the numbers that you cited, I think are very good kind of reference point for us to know as we kind of plan going forward. So thank you.
Thank you. And as the chairwoman indicated, I've forwarded to her, and I assume she'll share, or she indicated she would share that with all of the committee, that full report from George Washington University.
I will indeed do that following this hearing. Alderwoman Martin had to leave. Alderwoman Navarro.
Thank you. I don't have any questions. I found this very helpful, and especially having the perspective of what's going on in other parts of our state. So thank you very much for being here with us today.
Again, St. Louis is my home, so I'm glad to do it.
Alderwoman Middlebrook. No, she had to hop off. Alderwoman Rice, questions for Mr. Malone?
Thank you. I don't think I have any questions. I just also want to echo thanks for joining us today and for the information that you have. And just thank you, Chairwoman Spencer, for calling this meeting as well. I think one of the most important things that we can do for our constituents right now is be open and transparent with information so that we know what world it is that we're walking out into as people start to move around a little bit again. It's, the danger of locking down too hard or opening up too quick. A lot of this is trust in our government, is trust in the information that we have, and the more out front and transparent we can be, I think the more confidence we have that we are physically going to be safe, mentally that we have the resources that we need, and economically as we go forward as well. We can't do any of these things without trust in our government and in the health of the people around us as we move around. So this is really important, and I hope we can continue these kinds of conversations as the pandemic continues.
Thank you.
Alderman Todd, do you have any questions for Mr. Malone?
I don't have any question, but I want to thank the doctor for appearing. The information was very good, and I would like to thank you, Madam Chairwoman, for calling the meeting. The meeting has been very well informational. Thank you.
Thank you. Thank you, Alderman Todd. I wanted to point out too, that Missouri remains one of the few states that isn't putting forward a statewide plan. NPR reported earlier this week that there are only 6 states not initiating a statewide plan for contact tracing. So that really puts cities like St. Louis at a disadvantage for not having that. We're grateful to have those 3 or 4 state employees helping us, but that certainly isn't a statewide plan. This virus knows no boundaries, and even I'm grateful and encouraged to hear the coordination between the two health departments, at least in the city and county. We have a much broader problem, a broader issue than just that. Thank you so much, Mr. Malone, for sharing with us today. We have a couple of additional questions I know from the committee and for myself, for Ms. Thomas. The training associated with becoming a contact tracer, how long, I know you said, we have all those 12, 13 people that have been cross-trained. What is that to kind of step in? What does that training look like? How long does it take to get trained up to be a contact tracer? I know there's a lot of sensitivity. There's cultural sensitivity when you're asking people to share really intimate information. Sometimes, who have you been in close contact with? Information you may not want your mom or your spouse to know, frankly. There's a sensitivity there that's required, and there's some training associated with being able to do that effectively. How long does it take us to train up a new employee, get them up to speed?
Yeah, so if we're talking about a brand new disease investigator, so not just for COVID tracing, that could take, kind of depends, because we get them to be CDC trained. And then, so a lot of it is a couple of modules that can be extremely time consuming. And then there's also some, I'm trying to think, because it's been a while since I've taken it, but it used to be called passport training. So I don't really remember exactly how many days that training is. It used to be in person. Now it's a lot of modules that are online. So that's one piece of it. That could easily take a person a couple of weeks to complete those trainings. But then there's also in-house training, because you have different jurisdictions have different programs, so to speak. And then there's also the state web program that's called WebServe, and that's WebServe training, and we coordinate that with the state. Because that's how we get the case information and conditions that's housed in WebServe. So that's a separate piece. So I would, if I just had to give you a rough estimate of a brand new employee that's going to do disease investigation in general, not just specific COVID contact tracing, I would say probably maybe 6 weeks to even 2 months, just based on availability of different trainings. And then also, like I said, it can depend on the in-house training. Now, if we were to look at just specifically contact tracing, and because also a piece of disease investigation is, as you alluded to, is called motivational interviewing. And that's a technique that allows you to get established rapport with the client, to get that kind of information out of them so they feel comfortable with giving you information, especially like Dr. Malone has spoke about earlier, syphilis. You're asking somebody to give you sexual history. And so that takes a different, that's a skill, right? And so, but if we're talking specifically in contact tracing for COVID, I have seen a couple of online contact tracing. The one I saw on last week was from Johns Hopkins. And it's originally $49, but it's free. And it goes through different modules on contact tracing. I think it'll take a few hours to complete that. So I think if we are just doing training for contact tracers, I think that specific piece probably can be done in a couple of days. And that probably would also include, just like some in-house protocols on, quarantine letters, incubation period, those type of things that are going to be kind of different from each health department, because the way whatever systems that we have in place.
Okay, thank you. And regarding some levels of sensitivity, do we have contact tracers currently on staff that speak other languages, Spanish? I know we have a huge Bosnian population and other communities for whom English is not their first language. Do we have any capacity there?
Yeah, we do have staff in communicable disease who speak Spanish. That is the only other language. We do use the assistance of the language line and the International Institute for translation services when necessary. And we have done that.
And I know from some of my committee members, there's a couple of additional follow-up questions for you. So I'll go ahead and turn it over to some of them. Alderwoman Ingracia.
Thank you, Madam Chairwoman, and thanks for hanging in there with us, Ms. Thomas. I can't tell you how helpful and thoughtful your presentation has been. And just had two quick follow-up questions. The first is, since not everything is being entered into Qualtrics, how is data being aggregated or culled to make sure that there's like one place where all of the data is contained to make sure we have like a big picture look at what's happening on the ground?
Yeah. So that has been a challenge because all systems don't talk to one another, right? So like for example, Qualtrics doesn't necessarily speak to WebServe, and WebServe is the state database. And then we also have an internal city database that we track the cases that we are currently doing, you know, divided up. It's I'm actually really proud of it because one of our team members actually designed it, and it's really awesome. But it doesn't talk to the state database, and it doesn't talk to Qualtrics. So that has been a challenge. We do have some extremely talented EPIs who've been able to pull together those pieces. And so we can, you know, make the data make sense. They also send out EPI reports daily to kind of look at what we're seeing and trends, and to kind of compile the data that is kind of existing in a couple of different places. But you're right. So everything isn't necessarily in Qualtrics, and then we have some internal databases that we use to track that information.
Okay, well, I'm just happy to hear that you didn't mention carbon paper, because I do know that there are some city offices that still use carbon paper. And my last question is, when folks who pass away who haven't been tested for COVID, are people being tested post-mortem for COVID so that we have an understanding about, I guess, a better understanding of who actually may have had the disease?
Yeah, not to my knowledge. I would say that not to my knowledge. I can follow up with maybe the EPI or the medical examiner's office, but not to my knowledge.
Okay, I can do that. I'm sure you have enough to do. Yeah.
Well, yeah. I guess it answers the question. We're not, at least we know we're not tracing those deceased individuals who are post-mortem diagnosed. So that could be a bit of a discrepancy, maybe an area to increase what we're tracing, because certainly as people are, if they are diagnosed post-mortem, we should trace their contacts if possible.
Okay. I'll check in with the medical examiner's office, Madam Chairwoman, and get back to you, Ms. Thomas. And Ms. Thomas, again, just thank you. Thanks for all you're doing.
You're welcome. Thank you.
Alderwoman Tyus left us. Alderwoman Green, do you have additional follow-up questions for Ms. Thomas?
I do not, but thank you for being here today and sticking it out with us.
Thank you. No problem.
Alderwoman Martin left us. Alderwoman Navarro. You're good? Okay, Alderwoman Middlebrook left. Alderwoman Rice.
I'm good as well. Thank you so much.
Alderman Todd.
If I attend a ward meeting, and let's say sometimes there are 30 or 40 people there, and I stay 6 feet away from them, and somebody in the ward meeting tests positive for COVID-19, should I be quarantined?
Were you wearing a mask?
Yes, let's say I'm wearing a mask, and I stay 6 feet from everyone at the meeting.
Yeah,
and,
I would say your transmission rate is likely low, but hopefully we don't have any ward meetings where 45 people are showing up in person.
Okay. Thank you.
You're welcome.
For the record, my ward meetings have much higher attendance than that. Kidding. Okay, we're getting on 2 hours now, so I do want to wrap this up. Ms. Thomas, Mr. Malone, thank you so much for spending an enormous amount of time with us. Of course, we all know that contact tracing is one of the most important and critical pieces in stopping the spread of COVID-19. So while this wasn't a lot of time, this is an incredibly important issue. Ms. Thomas, your workload is already very high, very heavy amount of workload that you already have to do. So taking some time out from what you're doing to spend with us has been enormously helpful, but it also is helping us understand and appreciate your job, the needs that you have, and how much more complicated it's about to become. So we hope you got a good night's sleep last night, because that might not be available to you moving forward. We are here to advocate for you. You can hear how much we care about this issue. We care about the public health of our community, and we want to back up everything that you need to be able to do your job and help and trace every single person down to the last individual that they've been in contact with. So we will certainly be inviting you back. We will need some time to digest what we took in today, but with that, I want to thank everybody, and we're grateful for everyone's time and expertise here on the issue. With that, I'll entertain a motion to adjourn the health. Oh, you know what? I did want to say we didn't have any absences. No needed to do that, right? We covered all orders of business. Got it. And with that, I will entertain a motion for the adjournment of the Health and Human Services Committee.
So moved. Second.
Great. Hearing no objections, Health and Human Services Committee has come to an end.